and the leading and treating obstetrician and gynecologist. They need a prompt medical attention, and a very experienced OBGYN is needed over there. Early intervention is needed, good medical care is needed. It will significantly improve the outcome both for the mother and the baby. So reducing the maternal mortality as well as morbidity and perinatal mortality and morbidity, management of the preterm labor is a very crucial subject, and it should be taken very seriously. Now, how we define this is a preterm labor. Number one, because with the presence of contractions of the sufficient strength. Number two, frequency to affect the progressive effacement and the dilatation of the cervix, especially between the 20 to 37 weeks of gestations, are included into the preterm labor. Overall incidence of preterm labor is 6% to 10%. In a spontaneously, it can be 40 to 50%. If there is premature rupture of the membranes, it's a 25 to 40%, and obstetrically indicated is 20 to 25%. Though we have to reduce the perinatal mortality and mortality in cases of preterm labor, we should know there are few risk factors which are very much concerned with the preterm labor. The first is the previous preterm delivery. Socioeconomic status with preterm labor is very, very important. Maternal age is another important. If she is less than 18 or more than 35-40 is also one of the reasons for the maternal factors. Then if she is having the preterm premature rupture of the membranes is another point. Multiple gestation with all the ART clinics and infertility treatments, chances of multiple gestation, and that is also one of the reasons and the maternal factors for this. Then all second trimester abortions, maternal complication can be medical or obstetric, can lead to preterm labor. For example, if she is having diabetes, if she is having hypothyroidism, if she is having hypertension, all this can lead to the preterm labor. Then in a remote area or the rural area or educational status is not good, any lack of prenatal care can lead to preterm labor, and smoking is another important point. Now, when we discuss about the risk factors, we divide it into three ways: uterine causes, fetal causes, and placental causes. When we talk about the uterine causes, if there is a presence of myoma, submucosal or subplacental, can lead to preterm labor. If there is a uterine septum, bicornuate uterus or cervical incompetence is there, then it can lead to preterm labor. Fetal causes, if already there is a intrauterine fetal death or intrauterine growth retardation, can be of any other reason, can lead to preterm labor, or the congenital anomalies in a fetus is also one of them. In the placental causes, any abnormal presentation can lead to this preterm labor. Now, the risk factors, again, we divide it into genital, intrauterine, and extrauterine. That's a genital, can be a bacterial vaginosis, can be a group B streptococcus infections, chlamydial infections, or a mycoplasma infections. Intrauterine is an ascending form of genital tract infection. They can lead to this thing. Then any transplacental, transfallopian, or iatrogenic invasive procedures or anything can lead to, this is the intrauterine infection, and that can end up into the preterm labor. Extrauterine is the patient can be having the pyelonephritis, typhoid fever, listeria, malaria, and the parvovirus or asymptomatic bacteriuria. All these infections are there, can be genital, intrauterine, extrauterine, can lead to preterm labor. Now, another important point is the prediction of the preterm labor. How to say that this preterm labor is there? Number one is the risk factors we should be worried about. Then home uterine activity monitoring, that is HUAM. All the uterine activity, if it's been taught properly, preterm antenatal care has been given properly, she has been counseled properly. So this can be a count of the uterine activity monitoring is another important. Cervical ultrasonography means the assessment of the length of the cervix, which will have this thing. Salivary estradiol and the screening of bacterial vaginosis and screening of fetal fibronectin. So these are the prediction for the preterm labor. So if we'll find out any risk factor is there, there are chances of the layer, so we can predict the preterm labor. uterine contractility, then assessment of the cervical length. Cervical salivary estradiol is also can be checked, and the bacterial vaginosis and the fetal pectin is important over there. So when we can do the fetal fibronectin testing, the sample is from the posterior fornix of the vagina is being taken. The indications in the symptomatic preterm labor between the 24 to 36 weeks, the membranes are intact and cervical delimitation is less than 3 centimeters. The contraindications for this testing is that already there is a ruptured membranes, or there is already vaginal bleeding, or there is a cervical cerclage in situ is there, and we are doing the fibronectin, chances of the wrong results may be there. And relative contraindication after the use of lubricants or disinfectants being used for the just for the examination or anything, and within 24 hours of the coitus or any vaginal examination has been done. So this is a relative contraindication for fetal fibronectin testing. Now, how we can prevent the premature labor or the preterm labor? The primary prevention, there are two, the aims are lower the prevalence of premature labor by improving maternal health in general, by avoiding risk factors before and during the pregnancy. So overall, increasing the good maternal health care, good maternity cares, good health promotion is being done. This can reduce the, preterm labor can be reduced. And otherwise, the other measures by smoking cessation, good nutritional counseling, then lower the workload from the women with the stressful jobs can also be one of the ways for the primary prevention. Now, for the secondary prevention is otherwise early identification of the pregnant women with the risk of preterm labors, and they can help to carry their pregnancies to them. And how, what measures we can take? It's a swell measurement of the vaginal pH. It can be done for the bacterial vaginosis. Then cervical length measurement by TVS, we should know the length. Cerclage and complete closure of the birth canal, and progesterone supplementation is a secondary way of putting the prevention. Now, once it's established it's a preterm labor, what should be the treatment protocols? First and foremost, inhibition of the uterine contraction. That's more important. Number 2, the corticosteroids to induce the fetal lung maturation. Number 3, treatment of the infection with antibiotics. And 4th is the bed rest or the hospitalization is needed. Now, tocolysis. Tocolysis is suppress the uterine contraction and delay the preterm delivery. It has got 2 more important aims over there, that we allow the utero transfer to an appropriate facility and allow for the administration of the corticosteroids. While giving the tocolysis, we will increase the utero transfer also, and the corticosteroids can be given in future also with it. Now, tocolysis, there are contraindications. If the gestation is more than 34 weeks, labor is too advanced, the 5, 7, 7, 8 centimeter is there, then there is no use. If there is a fetal death, there is no use of tocolysis. If there is a lethal fetal anomalies like a big anencephaly or something like that, it should not be given. And then if there is a suspected fetal compromise, for example, severe IUGR, retarded fetus or something like that, when we are worried, we should not do the tocolysis. Same with the placental abruption. Placental abruption can be due to the hypertension, can be due to any other things, or then at that time it's contraindicated. Then if there is a suspected intrauterine infection, if the patient is complaining about any other thing, that the fever, chills, rigors, anything, and can be a chances of intrauterine infection, at that time the tocolysis is contraindicated. And the most important is if the patient is hypotensive, for example, her BP is less than 90 millimeters of mercury, the tocolysis should not be done. Then relative contraindication again with a multiple pregnancy, preeclampsia, and if already there is a rupture of membranes or placenta previa, the tocolysis should not be done. The tocolytic drugs are used in a clinical practice are, first is the calcium antagonist or the nifedipine, then oxytocin receptor antagonist, that is the atosiban, then inhibitors for the prostaglandin synthesis, that's the indomethacin, then no donors is a nitroglycerin, then beta mimetics can be a terbutaline, ritodrine, anything, and most important, another one is a magnesium sulfate. So we can categorize right from nifedipine, atosiban, indomethacin, nitroglycerin, terbutaline, ritodrine, or magnesium sulfate over there. This is a chart which we can show how the beta mimetic drugs acts, how the at which level the nitroglycerin will act, and what are the role of inhibitors and antagonists at different level. At the end of the time, there is a mechanism of action of tocolytic drugs is they mimic the adrenergic receptors and they act on it. So calcium channel blockers, that's nifedipine. The dosage is 30 milligram loading dose, then 10 to 20 milligram every 4 to 6 hours. Contraindications, if patient is already having cardiac diseases, renal diseases, maternal hypotension, we should not give, and avoid concomitant use of magnesium sulfate. So if we are giving the nifedipine and the magnesium sulfate, we should be aware of it. Then kinship channel blockers, again the side effects are flushing, headache, there can be a transient hypotension, nausea, and the tachycardia also. And fetal and neonatal side effect, sudden fetal death and a fetal distress. So while using nifedipine, we should be careful and we should be worried about. Now the atosiban, this is a drug. This can be given initial dose 6.75 milligram over 1 minute and followed by the infusion of 18 milligram per hour for 3 hours and then 6 milligram per hour for up to 45 hours. But the contraindications basically none. With the maternal side effect, the patient can feel nausea, can have the allergic reaction and headache. And fetal and neonatal side effects are none. So it's a very good drug, but the cost and everything we should be careful and it should be monitored properly over there. The important drug, the dosage and administration is a 10 milligram patch for every 12 hours and continuous until the contraction ceases. So up to 48 hours. The maternal side effects, again, headache and hypotension. Contraindications, especially if the patient is having already headache, it should not be given. And fetal and neonatal side effect, it can lead to fetal hypotension. Neonatal hypotension is one of the points. Then the beta mimetics. The doses are the terbutaline is 0.25 milligram subcutaneously every 20 minutes to 3 hours. And the ritodrine is initial dose is 50 to 100 microgram and it is given IV because it's a 50 microgram per minute every 10 minutes until contraction ceases, and then thereafter any side effect or anything like that, then maximum dose can be given up to 350 micrograms per minute. There are maternal side effects with the beta mimetics. They are especially the hypotension and the pulmonary edema. So we should be very much careful and while treating it. Then contraindication is if there is an uncontrolled thyroid disease or there's some diabetes mellitus or the cardiac arrhythmias are there. In those conditions, this beta mimetic should not be given, but the side effects with beta mimetics in a fetal and neonatal are worrisome. They are tachycardia, there can be the hyperglycemia, arrhythmias, hypotension, myocardial ischemia, and hyperglycemia. These are the points which we should consider while giving the beta mimetics. We have to balance the things that given the beta mimetics, ceasing of the contractions are more in effect, or the fetal and the neonatal effect are another important point. Then the magnesium sulfate, this is very important drug and it's a very commonly being used. The loading dose is 4 gram magnesium sulfate, slow bolus over 15 to 20 minutes. And the maintenance dose is 1 gram per hour for 24 hours. Stop infusion if all the reflexes or the respiratory rate is less than 12, hypotension and the loss of patellar reflexes are there, and there can be a UDP is less than 100 ml in 4 hours should be worrisome. So if there is like this, so we are there. And contraindications is again hypersensitivity, hypermagnesemia, hypercalcemia it can be the if patient is on the myocardial drugs or the diabetic drugs over there or the heart block. These are the problems with magnesium sulfate are there. So the take-home message is routine administration of antibiotics for the preterm premature labor without premature rupture of the membrane is not recommended. Because of the rate of maternal infection is lower, but the pregnancy is not prolonged, nor reduction of the neonatal complication, there is no evidence that the bed rest absolutely actually lowers the rate of preterm birth. And this